I want you to think about the last time you spent serious money on a survival kit. Maybe $199. Maybe $279. Maybe $349 on something that had "tactical" in the name. Here's what a retired Navy corpsman with 18 years of service and 2 combat deployments told me when I showed him the contents of one of those kits. He looked at it for about 30 seconds. Then he looked at me. And he said, "I wouldn't use 60% of this if someone was dying in front of me. It's not ideal. I'd prefer something else." He said he would not use it. In about 6 minutes, I'm going to show you the exact item he carries instead. It's $14.97 at Walmart, in the sporting goods section. And it does something, mechanically, physically, measurably, that no item in any $250 survival kit can replicate. A retired Special Operations Corpsman walked me through a specific 5-step application technique in his garage in Tennessee. I've never seen this taught correctly anywhere else. This item has been sitting at Walmart for more than 30 years. Every corpsman knows about it. Every combat medic knows about it. The $250 survival kit industry has been selling you something else the entire time. That gap is what this video is about. Stay with me. When I say survival kit, I'm talking about the pre-packaged $199 to $299 complete survival kits on Amazon, at Base Pro, at Cabela's, and in every tactical gear catalog. Those kits have one structural problem. A specific, predictable, consistent problem that every retired corpsman and combat medic identifies, unprompted, within 5 minutes of talking about civilian preparedness. Those kits are assembled by marketing departments. Not by field medics. Not by people who have treated actual trauma wounds in low-light conditions with shaking hands and a moving patient. The result is a kit that looks comprehensive. There are a lot of items in the bag. They're neatly arranged. And roughly 60% of the medical contents are completely useless in a genuine emergency. 60% of a kit you paid $250 for. That's $150 worth of theater. A retired Army combat medic named Derek told me, on a good kit, maybe 35 to 40% of the medical contents are field relevant. On a bad one, it's under 20%. Under 20% field relevant. On a kit marketed as complete emergency preparedness. Here's what replaces all of it. One item. $14.97. We're going to build to it properly. Because if you understand the 3 ways those kits fail first, the item makes complete sense. Failure 1, the bandage problem. Every pre-packaged survival kit comes with bandages. Lots of them. Dozens. It looks like comprehensive wound coverage. Every single one is an adhesive bandage. Band-Aid style. The largest size tops out at 2 inches by 3 inches. Here are the wound types most likely to require field treatment in a genuine emergency. Lacerations from broken glass. Deep abrasions from falls on pavement. Puncture wounds from structural debris. Avulsion injuries, when a flap of skin is partially separated. Not one of those is an adhesive bandage wound. An adhesive bandage requires a clean wound, dry surrounding surface, intact skin, and a controlled environment. In a real emergency, every one of those conditions fails simultaneously. Derek told me, the most dangerous outcome in amateur wound care isn't that the treatment fails, it's the false closure. When you put a bandage on and think it's handled, you stop monitoring. The wound keeps bleeding under that bandage while everyone assumes the problem is solved. The assumption of control is more dangerous than the wound itself. Think about that. Then think about the adhesive bandage assortment in your $250 kit. Failure 2, the glove problem. Every pre-packaged survival kit includes gloves. Usually 2 pairs. Usually latex. Here's why every field medic brings it up unprompted. Pre-packaged survival kit gloves are thin single-layer examination weight. Designed for clinical settings, handling a tissue sample, doing a physical exam. Not for managing an actively bleeding traumatic wound with debris and a moving patient. You reach into a wound. The wound edge has irregular margins, glass shards, rough bone. The glove tears. You don't know the glove is torn until you remove it. A torn glove in a blood exposure scenario is more dangerous than no glove, because of false confidence. You believe you have protection you don't have. A retired Navy corpsman, 18 years, deployed in Helmand Province, told me he double gloves on every wound contact. 2 gloves per hand, every time, no exceptions. Most survival kits give you 1 pair total. That's not a kit. That's a prop. 1 pair of gloves in a $250 kit. That's the manufacturer's entire glove budget for complete emergency preparedness. Failure 3, the gauze problem. A retired Special Operations combat medic named Marcus, 12 years with SF, 3 combat deployments. Before I asked my first question he said, "I need to talk about the gauze problem." Pre-packaged survival kit gauze is almost universally non-sterile standard woven 2x2 or 4x4 gauze pads. The 4x4 pads work fine for minor wounds. For moderate to significant bleeding, they fail in 2 specific ways. Failure 1, size. A 4x4 gauze pad covers 16 square inches. Most significant emergency lacerations exceed that. A forearm laceration from a vehicle accident routinely goes beyond what a 4x4 pad can cover. Failure 2, absorbency. Standard woven gauze saturates under active bleeding in under 2 minutes. Once saturated, it becomes a blood-soaked barrier between your hands and the wound. The single variable that determines outcomes in traumatic bleeding is sustained, correct, consistent mechanical pressure applied directly to the wound site. Pressure creates conditions for clotting. Pressure is the intervention. If your gauze is too small, pressure fails at the wound margins. If it saturates in 90 seconds, pressure fails at the center. If you run out before the wound clots, which happens with 3 4x4 pads, you run out of intervention. Marcus told me, "I have seen people survive wounds that should have killed them because someone held pressure correctly for long enough. I have seen people die from wounds that were survivable because the pressure failed." The wound is not the determining variable. The pressure is. 12 years. 3 deployments. 200 hours of field medicine. That's what he brought back. 1 sentence. Now. Here is the $14.97 item. Before I say the name, it is not a secret in the military medical community. Every Navy corpsman, every combat medic, every Special Forces 18D knows exactly what this is. It has been standard practice in U.S. military trauma medicine since the early 2000s. Developed in Israel in the 1990s specifically to address the failures of conventional wound dressings in field conditions. The Israeli bandage. Also called the emergency bandage. Manufactured by Persis Medical. Available at Walmart, 4-inch version $12.97, 6-inch $14.97. For integrated capabilities in a single item. Capability 1, Sterile Absorbent Dressing Pad. The pad on a 6-inch Israeli bandage covers approximately 6 by 8 inches, nearly 3 times the surface area of a standard 4x4 gauze pad. Capability 2, Elastic Retention Bandage, wide-weave elastic that maintains consistent tension throughout application, unlike standard gauze rolls that lose tension as the elastic fatigues. Capability 3, the Integrated Pressure Bar. A small hard plastic bar built into the bandage. When threaded and reversed, the bar acts as a mechanical lever, creating significantly more pressure than unassisted hand pressure alone can sustain. 1 person. Alone. Therapeutic pressure on a significant wound. Maintained without a second person holding anything. That's what the pressure bar delivers. Capability 4, Integrated Closure Clip. Locks the tension of the entire wrap indefinitely without pins, tape, or a second person. The pressure is locked in. It stays where you put it. One item. For integrated capabilities. $14.97. Every structural failure in the $250 kit, size, absorbency, sustained pressure delivery, addressed simultaneously. Each of those 4 capabilities, bought separately from a surgical supply catalog, runs between $5 and $20 per component. The Israeli bandage delivers all 4 for $14.97. Marcus walked me through this technique on a training mannequin in his garage in Tennessee. He calls it, pad, pull, wrap, lock, anchor. 5 steps. In order. No improvisation. Step 1, pad. Place the sterile dressing pad directly over the wound. Center it. Press with the heel of your palm. Do not lift your hand. The most common mistake at step 1, placing the pad and immediately starting the wrap before manual pressure has been established. Your hand creates the initial pressure. The wrap maintains it. Step 2, pull. With your free hand, take the bandage tail and pull it out and away from the wound before the first wrap contacts skin. You want tension in the bandage before it starts moving. Pull the tail until you feel resistance against the pad's connection point. That's your starting tension. If the first wrap is applied with slack, the subsequent wraps won't achieve consistent tension. Step 3, wrap. Make one full wrap around the limb above the wound, above it, not over it, before introducing the pressure bar. Most people skip this step. When the bar is introduced without an anchoring wrap, the pad shifts laterally under bar tension. One full wrap above the wound anchors the pad. It cannot shift. Step 4, lock. Thread the bandage tail through the loop on the pressure bar. Pull the tail back across the wound in the opposite direction, reversing the wrap direction at the point of the bar. You will feel the dressing compress down significantly as you pull. More than you expected. That compression is the mechanical lever effect. That is therapeutic pressure, the kind that creates clotting conditions. Step 5, anchor. Make 2 full wraps above the pressure bar. Then secure the built-in closure clip over the final wrap to lock all tension in place. Done. One person. One item. Marcus told me, practice this until you can do it in the dark. One-handed. On yourself. On a person who's moving. Under stress, with your heart rate elevated. Not because the steps are complicated. Because your hands need to execute without your brain directing each movement. In a real emergency, your brain is going to be managing the situation. If the technique requires conscious thought, you'll miss steps. The technique has to live in your hands. That's what practice gives you. Not knowledge. Automaticity. You cannot watch this video and have automaticity. You can watch this and have knowledge. Marcus practices trauma skills every 90 days. On a training mannequin. With a timer. He's had his credentials 14 years. Every prepper video focuses on the worst-case scenario. The arterial bleed. The gunshot wound. But Marcus told me something that shifted my entire frame on field medicine. The wound type I expect to treat most in a grid-down scenario is not a gunshot. It's what I call the Category 2 wound. Serious enough to require real management. Not serious enough to kill you immediately. The wound that gets infected. The wound that impairs function. The wound that isn't a big deal at hour 0 and becomes a real problem at hour 48. Deep lacerations. Puncture wounds from structural debris. Large abrasions from falls. Burns requiring compression dressing. Joint wounds, knees, elbows, where standard bandaging fails because movement constantly breaks the seal. In a grid-down scenario where medical care is 24 to 72 hours away, a wound that progresses to infection is not just a medical problem. It's a capability loss event. Wound edge approximation. The elastic tension combined with the pressure bar holds wound margins in physical proximity, the mechanical condition required for primary closure to begin without sutures. Edema control. Sustained compression reduces fluid accumulation in the wound bed, the primary driver of the inflammatory response that precedes infection. Less fluid equals a less hospitable environment for bacterial growth. Dressing stability through movement. The person with a knee wound is going to move, work, do what needs doing. A standard bandage on a moving joint will be partly displaced within 4 hours. The Israeli bandage maintains position. Marcus said, civilian prepper medicine is focused almost entirely on the acute event. Almost no one plans for the 48-hour consequence. In an extended grid-down scenario, that is the medical event I expect most. If you're replacing a $250 kit or starting from scratch, here's exactly what Marcus told me to buy. His principle first, build for probability, not for fantasy. What are the 5 most likely things to go wrong medically? Do you have the right tool for each one? Item 1, Israeli bandage, 6-inch. $14.97 each. Minimum 2 for a household, preferred 3 or 4. Single use once applied. For bandages is $59.88, still less than a $250 kit, exponentially more capable. Item 2, saline wound wash, 7.1 Oz pressurized can. $5.97. Walmart first aid section. The most commonly missing item from civilian trauma kits. Wound irrigation is not optional. Physically flushing a wound under pressure before dressing is the single most effective field intervention for infection prevention. Pouring clean water from a bottle does not achieve the same result. The can provides pressure. Item 3, nitrile gloves, 100 count box. $9.97. Not the 2 pairs in the survival kit. 100 pairs. Double glove every contact, 2 gloves per hand. That's 25 fully double-gloved wound management sessions from 1 box. Item 4, 3M micropore paper medical tape, 1 inch by 10 yards. $4.97 per roll, buy 2. The only tape that adheres reliably to skin that may be slightly damp, and can be removed without tearing skin or disrupting a healing wound. Item 5, non-stick gauze pads, 3 by 4 inch, 10 count. $2.97. For wounds that don't require a full Israeli bandage. Non-stick is critical, standard gauze adheres to drying blood. When you remove it, you remove the clot. Item 6, alcohol prep pads, 200 count box. $3.97. Skin surface decontamination around wound margins. Hand decontamination without running water. Equipment surface wipe down. 2 cents per pad. There is no scenario where you have too many. Complete kit, 2 Israeli bandages, saline wash, 100 nitrile gloves, 2 rolls paper tape, non-stick gauze, alcohol prep pads. Total, $62.76. Against $250. The $62.76 kit outperforms in every field-relevant category. Marcus's final word on kit building: the industry has convinced civilians that more items equals more capability. It doesn't. 5 items that do exactly what they're supposed to do beats 200 items that photograph well. Build your kit like a corpsman. Not like a catalog. The Israeli bandage is not a substitute for training. A correctly applied bandage in trained hands is a powerful intervention. In untrained hands, still better than a $250 kit. But not the ceiling. Marcus said, the best use of money you save not buying a $250 kit is a Stop the Bleed certification. Free. 2 hours. At the end you'll know how to pack a wound, apply a tourniquet, manage a sucking chest wound, and hold pressure correctly. Those 4 skills cover 90% of traumatic injury scenarios you'll actually face. Get the certification. Then build the kit. No affiliate link. No paid mention. Just what Marcus told me to tell you. As I was walking to my truck, Marcus called after me. "I forgot the most important one," he said. Like it was so fundamental it hadn't registered as something to mention, the way you wouldn't think to mention breathing while teaching someone to run. Light. A headlamp. A hands-free light source kept with your medical kit at all times. Not a flashlight. Not your phone's flashlight. A headlamp. Hands-free. Every trauma skill I've ever been taught assumes adequate lighting. But real wounds happen in the dark, in a car crash, a power outage, a collapsed structure. You cannot see what you're doing without light. One person, alone, treating a wound in the dark without a headlamp, their effectiveness degrades significantly. That degradation might be the difference between a wound that's managed and one that isn't. Military trauma research shows wound management effectiveness decreases by approximately 35 to 40% in low-light conditions, even for trained medics. 40% degradation. The absence of a headlamp cuts your capability nearly in half. Marcus's specific recommendation, the Petzl Tactica, approximately $24.97 at Walmart Sporting Goods. 350 lumens. Red light mode. 3 AAA batteries. He keeps one in his medical kit, one in his truck console, one clipped to the wall beside his bed. Complete kit with 2 bandages and headlamp, approximately $72.76. Versus $250. Better field performance across every category. The training, Stop the Bleed certification. Free. 2 hours. Marcus said at the very beginning, before any items, before any technique, the question isn't whether you're going to face a medical emergency. The question is whether you're going to be the person who can do something useful when it happens, or the person who stands there with a $250 kit and watches the outcome go in the wrong direction. That's the gap this video is about. Not between cheap and expensive gear. Between theater and capability. Stay sharp. Stay capable.